and I'm from the Umeå University in the north of Sweden. The topic of today is unmet needs in medical treatment in glaucoma, and I would like to thank the organizers for their kind invitation. So first, the disclosures you can see here before we begin. So I'd like to exemplify the unmet needs we have in medical treatment in glaucoma by telling you about a patient of mine. We can call him Gunnar. Now, he's a male, 68 years of age, was diagnosed some years back with POAG on his left eye. Now, he presented with several risk factors you can see here on the slide, high intraocular pressure, and you can see his visual field here with a nasal step, a small mild defect, as well as a thinning of the retinal rim on the optic nerve head inferiorly. Now, he was treated with a prostaglandin analog with a target pressure of 18 millimeters of mercury. Now, during the initial follow-up, the IOP levels were above the expected target pressure, about 25 on each eye, and didn't really go as low as possible. And when questioned, the patient admits that he may forget the drops from time to time. And this exemplifies the first unmet need we have. We need medical treatment that will improve adherence of the patients. Now, non-adherence is common amongst glaucoma patients. We know that as much as 50% of the patients probably aren't taking the drops exactly as we have told them to do. And also, it's good to know that patients often overestimate their adherence. Some patients, they take the drops really thoroughly just before coming to appointment and then drift off. We can call this white coat compliance. So how can this be solved? And actually, there are things in the pipeline that might help us. An example of this is slow release implants that are, some of them having phase 3 trials at the moment. Here you have an example of the Biomotoprost biodegradable intracameral implant, which is now in phase 3, and there are others in earlier stages as well. So hopefully this will help adherence in some of our patients. Now, if we go back to Gunnar, our case, later during follow-up, he came to an appointment and was quite unhappy. He was complaining about red eyes, stinging sensation, and irritation. And this leads us to the second unmet need, which I've identified, which is less local side effects. Now, many patients do suffer from local side effects. Some of them are connected to preservatives. Had we gone 50 years back, this would have been an unmet need then, but now we have met these needs. But others do react to just the active components or other components in the drops. Now, the current practice is if the patient isn't tolerating it, that we treat through laser or surgery. But and it isn't as clear how this will be solved in the future. Perhaps slow release implants will have less side effect locally. Perhaps we'll get oral treatments in the future, but the future will simply tell. Now, 2 years later, Gunnar, our patient, he has gotten increased treatment. He is now on fixed combination prostaglandin analog and a beta blocker. And at this appointment, he complains about dizziness and having nightmares. So he's not so happy now either. And here we have the third unmet need, less systematic side effects of our medical treatment. And just to show you how primitive really the eye drop drug delivery system is, and just show this figure. Now, here you have a normal tear volume of 7 to 9 microliters. Now, in an eye drop, it's about 35 to 50 microliters, which is a much larger volume, which means that in just instantly in the first couple of minutes, and most of that is drained away and goes down to the nasopharynx mostly, giving rise to potential systemic absorption and systemic side effects. And only 5% are getting into the eye, where it has its action points, action and point of action. So what this actually may be helped with the slow release implants that I mentioned earlier. But this is a real problem with having drops on the outside. Another thing that could help would be to have drops that actually stick to the eye for a longer time, but we don't have those available yet. Now, a fourth thing that I want to mention is when Gunnar, our case, comes back a few years later. Now he has gotten more treatment in forms of SAT, and he's getting preservative-free prostaglandin analog and carbohydrate inhibitor. Now he's learned how to take them, so he has good adherence, he tolerates them, and the IOP is really low. So now we're all happy, right? But in fact, the visual fields are actually going fast to the worst place. So the rate of progression is 4.5% per year, and obviously things aren't working. So what we need here is we need something that is IOP independent and neuroprotective treatment. And what is that? A therapeutic approach aiming to directly prevent or significantly hinder neuronal cell damage, as stated in the new EGS guidelines. Now, stated there and in a new Cochrane report is that there is currently no evidence to support the use of neuroprotective agents in glaucoma. There are a couple of substances that are registered for glaucoma in a few European countries, but the evidence is low. So there have been many agents that have been tried in trials, but none successful so far. But I'd like to draw your attention to one candidate that might actually succeed, and that's nicotinamide, or B3 vitamin. Several animal models have shown positive effects on neural damage when this is you get nicotinamide supplementation. And as a matter of fact, there is a pilot study from last year showing improvements in visual function in a short-term patient trial. So hopefully we'll get some results from studies like these in the future on patients. So in conclusion, we have several unmet needs in medical glaucoma treatment. We need drugs that improve adherence, cause less local side effects, increase absorption into the eye, and thus lessen systemic side effects, and drugs that are never protective. So hopefully these needs will be met in the near future. And with that, I'd like to thank you for your attention.